I'm Anthony Leeds. It's my pleasure to welcome you to the next episode of our discussions with Professor Shahrad Taheri, who last week discussed the studies that were undertaken in the Middle East in relation to achieving diabetes remission and all the various consequences of that in terms of changed metabolism. Shahrad, thank you for joining us again this week. At the end of last week's discussion, we were talking about fatty liver and its importance, and you also gave us some clues about some other exciting things that are in the pipeline. But perhaps we could concentrate for the moment on the question of fatty liver and the importance of it. My understanding is that at the present time the view is that at least 38% of the adult population globally have a degree of fatty liver. So I suppose we should begin by describing for the viewer what exactly do we mean by fatty liver, what are the causes, and then how does it progress? If you don't do anything about it, what are the consequences of having a fatty liver?
So fatty liver is basically excess fat in liver cells, and liver cells, when they're so stressed for any reason, they tend to deposit fat. And one of the major sort of ways of causing stress to the liver cell is excess alcohol. We've known that for a long time, and alcohol results in hepatitis, which eventually develops into fibrosis and then cirrhosis, and also liver cancer. But it was also noticed that actually there are people who actually don't drink that much alcohol or don't drink alcohol at all, and they tend to have excess liver fat. And this became known as non-alcoholic fatty liver disease, NAFLD. It was further recognized actually. What happens with fatty liver is when there's excess fat in the liver, the next step is what we call steatohepatitis, which is inflammation of the liver. And then when there's inflammation, then the liver responds to it through fibrosis by trying to sort of maintain that inflammation control that inflammation. And that fibrosis develops a cirrhosis where the liver shrinks and becomes nodular, and then that can develop into hepatocellular carcinoma. So this can happen without alcohol and can be due to excess liver fat deposition for whatever reason that is. Now, we know there are individuals with rare genetic disorders, basically enzymes that affect lipid metabolism, that can also deposit excess body fat. But these are the very minority of individuals who develop fatty liver. But most of the people who develop fatty liver is related to excess body adiposity, because when we have excess fat, initially we deposit it in the subcutaneous tissue, but our subcutaneous tissue is limited in the storage of fat. And eventually that spills over into the viscera, and the liver is one of the biggest metabolic sort of factories in the body, and tends to store fat as it does glucose in terms of glycogen and things like that. So what was realized is actually the liver disease itself, when there's excess body liver fat in terms of developing cirrhosis and hepatocellular carcinoma, etc., the progression is actually very small. So it's like 1 in 10 individuals in between every stage that gets the final stage. Nevertheless, it's really important because nowadays excess fatty liver is the greatest indication for a liver transplant. And it's thus of concern to hepatologists. But the other thing that was noticed was that people who have excess liver fat are also at risk of excess cardiovascular disease. And this resulted in somewhat changing the terminology. Initially, then it was called metabolic associated fatty liver disease. And now metabolic associated steatotic liver disease is the term that is being used. And before, the hepatitis was called non-alcoholic steatohepatitis. Now it's metabolic associated steatohepatitis, called MASH. So we went from NASH to MASH. So the idea was that the recognition actually can have cardiometabolic consequences, change the focus in terms of trying to manage this disease.
Yeah. Now, a key question that people will be thinking is, well, how do ordinary people know whether or not they've got fatty liver?
That's absolutely very difficult to know.
That's why I asked the question. Yes.
Obviously, there are indicators. So like I said, you have to have issues in terms of body fat storage. And some people tend to, particularly in South Asia, tend to store body fat more within the viscera than within the subcutaneous tissue. So it's very difficult to know because they may look slim in appearance, but actually the fat is in the wrong place. It's very difficult to ascertain that. But certainly if the body mass index, which is a weight in kilogram over height squared in meters, is high for that population, knowing the range, and the waist height ratio is more than 0.5, then there is a risk of excess liver fat. Then there are blood tests that can be used as well to see whether there are risk of fibrosis or not. So there are certain scores that can be used to look at that, and ultimately imaging is the way forward in terms of understanding liver fat. So that will require ultrasound. So ultrasound will tell you whether there's excess liver fat, or we could use what's called elastography, which basically looks at not only how much fat there is in the liver, but also how stiff the liver is in terms of looking at fatty liver. And again, these are fairly easy tests to do, but they're not regularly available.
Yeah. We know that if an effective amount of weight loss, thinking perhaps of about 10 kilograms, will actually reduce liver fat quite quickly. Is there any evidence that if somebody has progressed to the stage where they have a degree of fibrosis, that actually losing weight can reverse the fibrosis, or once it gets to that stage, is it irreversible?
Well, we know that fibrosis takes a long time, so doing trials is going to be really difficult to do. But based on the information that we have with bariatric surgery, it's possible to drop down in terms of level of fibrosis with bariatric surgery. And this has been shown very nicely. So weight loss through bariatric surgery. But bariatric surgery is not just weight loss, but it's a change in the way the body manages metabolism as well. So that's important too. And the data emerging from this new weight loss medications that actually it's possible to go away from fibrosis, improve fibrosis score, as well as reduce liver fat. So weight loss can affect that. But 10 kilogram weight loss through diet is only possible through total diet replacement, because it's really, really hard to do with normal diet. And with normal diet, it's not going to be nutritionally complete. So people who have excess body fat are already deficient in many vitamins and things, and actually doing through diet alone without taking a sort of total diet replacement approach may not be easy to do and can have consequences down the line. So the way to achieve that 10 kilo weight loss can be, depending on the individual, can happen through total diet replacement. Can achieve 10 kilos of weight loss through bariatric surgery, through other interventions such as gastric balloons. There's a temporary temporal bariatric surgery. Complication.
Yeah. Now, if people have lost weight using a total diet replacement and have achieved the 10 to 12 kilogram weight loss, one of the difficulties is maintaining weight, of course, and a little bit of work is being done now to try to achieve some dietary interventions that will help people to maintain weight after weight loss with total diet replacement, such as using one meal replacement per day for one meal, and occasionally going back onto a total diet replacement. And I know there are more papers in the pipeline that describe some of these results. So what the question it raises is that if we know that sort of amount of weight loss will result in this change, which is beneficial, and we've already shown that in the United Kingdom that you can actually roll out a total diet replacement program using to achieve diabetes remission. What needs to be done now in terms of experimental evidence and translation into practice studies before we can apply appropriate forms of weight loss for fatty liver? Because if so many people, presumably in the UK it's something like 35-40% of the adult population, we can imagine that in 10, 15, 20 years' time, there are going to be an awful lot of people who are going to be affected, even though they may be one-tenth of the total number, are going to be affected by it. Shouldn't we be applying the same sorts of approach for fatty liver as we do for diabetes?
Yeah, absolutely.
What do we need to do? What do we need to do to get this to happen?
I think the first thing we need to recognize is there's no single solution for every individual. So the solution has to match that individual. And total diet replacement is a good way of reducing body weight sufficiently in certain individuals who are prepared to do it. And so are medications, bariatric surgery. So each of these has to be individualized.
Yep.
But having, the reason I'm a proponent of diet is that because it's a natural way of doing things, in the sense that medication do have side effects, and some of them could be quite severe and result in people not continuing with the medications. Bariatric surgery has got issues in terms of vitamin deficiencies and long-term issues. So it has to be matched to patients. So we've shown that with total diet replacement, it's possible to do type 2 diabetes remission on scale, on mass. So it's possible to do the same thing with fatty liver. Now, the problem that people will always say is that obesity is a chronic disease. It needs long-term management. But the problem is, including even with a sort of direct long-term follow-up, the follow-up has not been as rigorous as it should be to be help people maintain that weight. Now, people may think it's easier to actually just take a medication to do that, but there are other solutions. So provided there is the right follow-up, like you were saying in terms of single meal replacement and these kind of things, where the evidence has to come through to show that maintenance is possible in long term without medications, then it should be an option that should be presented to people. And to be fair, in my sort of clinical practice, not everybody wants bariatric surgery, not everybody wants medication. So you have to match that individual's requirements as well. And not many people tolerate total meal replacements. So it has to be matched.
Yeah. I think you also commented on sort of nutritional status, and although it would be good to have much more information about nutritional status of using total diet replacement, the trials on osteoarthritis in Copenhagen, where we did look at vitamin D and vitamin B12 status, did show that because the micronutrients in those things are bioavailable, you do actually improve nutritional status rather than watch it deteriorate, as often happens with many dietary interventions. So that's actually important. And critical micronutrients like magnesium, which are highly relevant to insulin function, may well be improved by taking that. So even where people are using the drugs for weight loss, they ought also to be taking a lot of effort over diet to ensure that the dietary intake is adequate. So the next question is, where do we go now? What's next as far as fatty liver is concerned in terms of the experimental work? What needs to be done now to take this forward? It's been recognized as being a major public health problem globally. People have got lots of plans, but what do you think? What are the priorities for next steps?
I think that what we've been advocating is policy change and guideline change and recognition of the disease. And that's really important. I always tell the story of the man whose house was on fire and his neighbor came and said, "Look, your house is on fire. Have you called the fire service?" He says, "No, I'm waiting for the alarm to go off." This is the sort of reaction that people, sort of policymakers have in terms of waiting for something bad to happen to be able to do effective approaches in terms of tackling these diseases. And fatty liver, metabolic associated steatotic liver disease, is going to be a major contributor to morbidity and mortality and healthcare costs down the line, as is type 2 diabetes and obesity. And unless we take that seriously, we're not going to progress. And we need to certainly advocate for policymakers to take it more seriously. Again, the problem with medicine is that the medical approach that we've been using is to treat a disease rather than prevent disease. and that model needs to change in a big way, and that's. Unless that happens, then it's very hard to provide services for patients. And these are all silent diseases. Type 2 diabetes can be a very silent disease early on, although people can have complications like eye disease and kidney disease when they present with type 2 diabetes. But fatty liver is also very silent until it's too late to actually act on it. So we need to really take these diseases seriously, move towards prevention. And reversal of disease. We've shown that if obesity is contributing to various diseases, and also several trials have shown things like preserved ejection fraction heart failure. So if you achieve sufficient weight loss, you can have some improvements. Of course, these drugs also have independent cardiovascular effects, but some of it is weight loss as well. So achieving sufficient weight loss can have improvements in many of these factors. There was a recent article in the New England Journal where they looked at the contribution of obesity to certain diseases, and with fatty liver, it's about 40%. So it's one of the major contributors to fatty liver. So we need to have policies to prevent obesity and reverse it.
So in fact, also methods for early detection as well would be critical. And you, in the previous discussion we had, you mentioned the proteomic studies where large numbers of proteins are examined, and it was very clear that there are some pretty good markers of fatty liver and presumably therefore fatty liver risk. And when those methods become less expensive and more widely available, presumably things like that can be used. But in the meantime, are there any other relatively simple, inexpensive tests that can be done or not?
I mean, it's in terms of sort of the problem with, like I said, the medical view is that we're more interested, the interest has been mainly in fibrosis. So most of the scores that are done in terms of blood tests are to do with fibrosis. And the protein panels are useful because they can tell us about a degree of liver fat, but also help us in terms of understanding fibrosis. And then other methods that's coming along that people are looking at, for example, proteins and metabolites in the urine as well as the blood, and also there's an interest in terms of doing certain breath tests to look at degree of liver fat as well. So the technology is coming along, but right now we're limited to imaging, and imaging is the best approach in terms of assessing. It's very simple to do in terms of ultrasound to gauge liver fat.
Okay, so as usual, underneath the window containing the video, we're providing short pieces of text and some links to websites which should be helpful to people in terms of helping them to decide what they might wish to do themselves. Of course, fatty liver is one of the problems often associated, well, very often associated with diabetes, but also obstructive sleep apnea. So in our next conversation next week, we're going to discuss obstructive sleep apnea. So Shahrad Taheri in Leicester, in the Department of Medicine in Leicester, thank you very much for talking to us. Thank you.